Good afternoon to everyone. First of all, let me take this opportunity to thank the organizers for allowing me to present this topic in front of this august audience. I must talk on PLC. As we all know, PLC is the darker side of the knee, and this is considered as a fifth ligament. I think in the next presentation we'll have a lot of video presentation on open technique. I would like to go for a minimally invasive and arthroscopic technique. Now, popliteus, as we know, it is dynamic as well as static, and the static part of popliteus is within the joint. It's not extraarticular. So it's a both extraarticular and intraarticular structure. And we know about the popliteofibular ligament now, and we know the stability created by the PFC, popliteofibular ligament. And this is the surgical landmark. And we all know that it is very difficult for the lateral side to heal, and you need some sort of a reconstruction more than a repair, unlike PMC injuries. So this is a popliteofibular ligament, and arthroscopic findings are when the PLC is injured, the drive-through sign is there, you see a lot of opening on the lateral side, posterolateral side. So grade 3 injuries, you need acute repair in Owl's fractures, but even in acute injuries, sometimes reconstruction is needed. So you have to correct the alignment, otherwise PLC is not going to function. So Laprade made a great advancement and publications in repairing the PFC, popliteofibular ligament, and the LCL, and this was an open technique. And there is nothing to pick up between the modified Larsen and R-Serio, so I am not going into the details. So the posterolateral reconstruction, the most important aspect of posterolateral reconstruction is that you can do an anatomical or a non-anatomical way of repairing it. And the importance of a fibular based technique is that superior fibular joint may be damaged, unstable, it may not work always. So a tibiofibular based technique has more relevance. So this is a preoperative assessment, and we need to know that you should not confuse between a PMC and a PLC injuries and a combined injury. So sometimes you will get mistaken by your clinical examination. So this is the original modified Larsen technique, which the next speaker is going to talk about. And in these injuries, what we have to decide is, are you going in for a modified Larsen, a Laprade, or a popliteus reconstruction? So which you choose. If the virus stress test is the only test positive, then you go for a modified Larsen. If virus stress test and dial tests are positive, then you go for a Laprade. And if the dial test is the only test which is positive, you go for popliteus reconstruction. That should be the sequence. So this is a technique of modified Larsen's procedure, and this is an open technique where it is a fibular based technique. There is not a tibial based technique. This is a arthroscopic popliteus reconstruction where you are going to create a tunnel from the tibia to the popliteal hiatus, and the femoral tunnel is just below the lateral epicondyle. So this will I come to in the next few slides. I will show the detailed video. So the LCL reconstruction has to be a more of a tibiofibular based technique, not just a fibular based technique. So we have an option of doing an open LCL reconstruction or a minimally invasive LCL reconstruction. So the minimally invasive reconstruction has the advantage of being so less invasive that post-op recovery is good. So this is the technique of a minimally invasive technique. You just put a drill from the fibular head to the tibia. It's almost a horizontal tunnel. Then you make a tunnel on the femur from just anterior and superior to the lateral epicondyle, and that is an oblique tunnel for around 45-degree angulated, and you pass the graft under the skin. So this is a less invasive technique because the next presentation is on open technique. I thought I will show this. So this tightening of the graft is done in 30 degrees of flexion. And now popliteus tendon reconstruction. Why do you want to do that? Because it is an intraarticular structure, part of which is extraarticular, but what we talk about is an intraarticular reconstruction. So it's minimally invasive, and deep structures need not be identified. You need not expose the common peroneal nerve. So these are the different publications on this, and this is a video on arthroscopic popliteus reconstruction. You establish posterolateral and posteromedial portal as you do in a PCL surgery, so that you can see, do a posterior triangulation. You can see on both sides, from the posterolateral side as well as posteromedial side. Next step is to create a tunnel which should exit in the popliteus hiatus. And the entry point of the tibia is in between the tibial tubercle and Gerdy's tubercle. If you go mostly on the medial side, you may injure the popliteal artery. So this is a very important step. So just lateral to the tibial tubercle, then you exit at the musculotendinous junction, that is the popliteus hiatus, that is a tibial tunnel, and then you make a femoral tunnel. It is just inferior to the lateral epicondyle, to almost 12 mm inferior, and then you make a femoral tunnel. Once you make a femoral tunnel, you can do a suture management. Now you have a single thread in your hand. Once passes through the fibular tunnel, then the femoral tunnel, and then you start passing the graft. The graft is passed from the tibial side. It comes to the joint at the musculotendinous junction at the popliteus hiatus area, and then to the lateral gutter. And from the lateral gutter, you have a tunnel on the femur, and that graft is passed on to the femoral tunnel. So this is the arthroscopic popliteus reconstruction. And here, once the graft is passed and is tight within, you first tension or put the femoral screw first, then in extension, and in extension you do the tightening of the graft. So this is an arthroscopic popliteus reconstruction. So this is a stable knee after that, and that is a complete video. You should be careful about the tunnel positioning. Tunnel should be little oblique, and then tibial tunnel also should be in such a way that it's not injure the popliteal artery. So you are going to be a little lateral, not too much medial. So when you make a mistake, there is a chance of popliteal artery injury, but it is less than the PCL injury. So you need not be worried about this technique, and popliteal artery is always safe, more safe than your PCL surgery. So this is about the arthroscopic popliteus reconstruction. I would like to conclude this presentation. If the virus stress test is only test positive, you do modified Larson. Virus stress and dial tests are positive, you do Laparade or arthroscopic popliteal reconstruction, and along with LCL. If the dial test is only test positive, you do only popliteus reconstruction. Thank you for patient listening.